The process was incredibly complicated in that they assembled an outstanding group of bladder cancer experts, people involved with seeing a large number of bladder cancer patients, being involved in bladder cancer research, bladder cancer clinical trials. They also had a number of patient advocates as well as outside participants in the process, but they really did a very extensive literature search, relying not only on the literature, because some of the literature is not as randomized, prospective as we would like, but they did have a number of discussions and debates back and forth to make sure that the expert opinion that they utilized was vetted. I think some of the key changes are the diagnostic changes. So there's certainly enhanced information about enhanced cystoscopy using photodynamic type of agents. We also have additional information on treatment for patients who no longer respond to BCG. I think one of the things that all urologists are familiar with is when to start BCG. Unfortunately, they're not quite clear on when to stop BCG, and that this guideline really helps put sense into that, makes it much more standardized. The algorithms are much easier to follow, and I think that they just did a wonderful job of picking 26 to 30 nice bullet points, but that are very succinct, easy to follow, easy to understand, with a very clean and standard language. I'm hoping that the urologist will very readily and easily be able to follow a standard algorithm, so that we'll get patients categorized, whether they're low risk, intermediate risk, or high risk. That will know when to do a repeat TURBT, when to utilize enhanced cystoscopy with Cysview. I think for me, it helps me define the disease more completely. I learn additional staging information. I think that I'm able to do a more complete TURBT. The evidence level for blue light cystoscopy in the guidelines is a evidence level B. It's based on a number of randomized prospective trials for patients with a negative white light cystoscopy but a positive urinary cytology, for patients that have a high-risk non-muscle invasive bladder cancer. In my practice, I find Cysview to be incredibly powerful, because I think that, as we've seen in other cancers, that the patient advocates are really the driving force, and that as physicians we need to continue to remind ourselves what we're doing and why we're doing and who we're doing it for. But there's no question that if patients become more sophisticated and ask the questions, well, why aren't I starting BCG, or shouldn't I be receiving BCG, or shouldn't I have another cystoscopy and a biopsy, and how come I'm not having the maintenance BCG and so forth? I think that those questions will help spur our urologists to standardize their management, which I think is critically important.